was flipping through Rick's presentation this morning, and I said, you know, this is perfect because you're really getting into a lot of the nuts and bolts about what it looks like to build these managed care systems and the pros and the cons. And our presentation has a little bit different flavor. It's kind of and what does it look like when it's working well? And a lot of what Rick identified as the kinds of issues, pitfalls, and challenges, we're also facing those. And where I can remember to tag on to what you said, I'm absolutely going to try to reinforce that message. But when it works, it's an amazing thing. And so Angela's actually got some videos at the end. So we're going to get started. Just very quickly wanted to describe for you the state of Michigan, which of course you know is the mitten state. And anybody who knows us, if you ask us where we live, we always hold up our hand and we point somewhere. Yeah. So I live like, you know, here in the middle of the state, and Angela lives like over here by the bottom part of the thumb. We are the 11th largest state in land area, the 9th largest in population. We used to be bigger, don't you know, because we were one of those states that did not gain population, right? I think we lost more population than just about anybody else. But we are a very urban and rural state, which a lot of you struggle with, and Washington is similar. Our UP is 29% of our land mass and only has 3% of our population. So. And then, you know, when you get into the urban areas like Detroit, we have in the second largest county, which Angela is referencing, the Detroit metro area, which is our Wayne County, Oakland County, and Macomb County, has, I believe, about a third of the entire state's population right in that one little area. So we do have almost 2 million Medicaid beneficiaries. It's 19.6% of our population is on Medicaid because, you know, when the recession hit, Michigan had already been in a recession for nearly 10 years. I liken it to we had a depression while everybody else was having a recession. And we had a 69% increase in our number of Medicaid beneficiaries between 2001 and 2010. So when Rick was talking about the pressures that you have on your rates, when you don't know how many people are coming in, it can be very challenging because in a managed care system, you have to serve everyone who presents at the door and meets your eligibility, and you have to make that work within the funding that you have, and you are required to have actuarially sound rates. So it's been a huge pressure on our system. But what I can tell you is we've gotten through it. We're on the other side of it, hopefully, moving forward. And we didn't drop anybody off, and we didn't have to reduce services. And it's been an incredible effort on the part of everybody to try to make this work. Most importantly, the people who are receiving services. Because when you can have conversations with folks, and I'm probably taking one of your lines, and you can just describe it better than I can and say, here's where we're at. And here's what we need, and here's what you need, and here's how do we find that middle ground, how do we compromise? And a lot of times we can be pretty successful with that, don't you think?
And I think the other thing is the state being candid and inviting real participation of the advocacy and disability community to say, these are the challenges we're sitting with, and full disclosure, help us figure out a way to get the goal of quality lives and supports and creating meaningful lives, and help us get there with the planning, construction, and redesign when we need to. And that's been a real critical element of practice.
So just very quickly, we are a very different organization from how Arizona is structured. We have our Department of Community Health, which used to be 3 separate departments. When I first started, the Department of Mental Health was a standalone agency. It is now part of our larger Department of Community Health, which includes our Medicaid agency, which is called Medical Services Administration, and the old Department of Mental Health, which is now called Behavioral Health and Developmental Disabilities Administration. Rolls right off your tongue. And then also our public health agency. It's our largest agency within state government. We are in that administration. We have 80 staff. And we're operating a $2+ billion operation with 80 staff. Now, how do we do that? We do that with not any real state staff doing the work. It's all delegated out. So, for example, underneath, you can see on the slide, we have 2 bureaus. I am part of the Community-Based Services Bureau, so my division of quality management and planning is underneath that. And Camille and I were joking about how you end up with a title that lots and lots of stuff fall under, right? So if you have a title that includes the word quality, chances are lots and lots of stuff are going to land there. So we just started. We're kind of a late adopter on this national core indicators that Rick was just talking about. That's in our shop. The quality strategy, all of the waivers are in my shop for having to write those, and we do those with 80 staff. We do not have a dedicated division for people who have intellectual and developmental disabilities because we've kind of structured in a functional way. And so we have a section under my division called Service Innovation, or I guess we just changed it, didn't we? We just reorganized, so we're changing the names of everything. It's now called Community Practices and Innovation, and it includes not only folks who have specialty in the evidence-based practices of mental illness and substance use disorder, but also now folks with intellectual disability, our experts, are in that same section. So we have a kind of a different thing, and we do have that partnership. We're going to talk about it in a little bit. One of the things that Rick talked about was you can either do it at the state level or you can do it in some sort of a partnership between state and a local entity. We have governmental entities that have created new entities that we contract with. So we'll talk about that more in a little bit. But that's how we do it with 80 people, and I won't tell you how many hours I work a week. But Camille and I were talking about that too, and Rick, it's really nice to be a consultant, right? Yeah, that's the goal at the end of the day, right? So I'm going to talk a little bit about part of this slide, and then Angela is going to take it from here. So here's our evolution. We started very much like many other states did by adopting 1915 C waivers. And I'm not going to spend a lot of time on mechanics. I know you have experts in this state who are the state staff that can sort out all the acronyms. But here's what it means when you hear something like a C waiver or a B waiver. Here's what it means. The Social Security Act has a number of different elements in it that give states the ability to do something a little differently with Medicaid money. So we are waiving some parts of what the Medicaid program would require in order to do something for a special population, for example, like people with intellectual and developmental disabilities. So a 1915C waiver, all that means is that's Section 1915C of the Social Security Act. All right? But everybody, when that new authority came in the early 80s or mid-80s, we all jumped on that bandwagon. Every state in the country had at least one C waiver, except maybe Arizona, because you guys went the 1115 route. I think there's about 450 C waivers around the country right now. In 1998, we moved to, and so Truvan was not quite correct on that, we moved to a concurrent BC waiver. There was another BC waiver in the state. It was in Texas. It was a little tiny program. We were the first state to move to a statewide concurrent BC waiver. Again, 1915B just being a part of the Social Security Act that allows us to do managed care. All right, 1915C being able to target to a particular population. Our 1915BC concurrent waiver serves all Medicaid beneficiaries in our state who have a serious mental illness, an intellectual or developmental disability, substance use disorder, or children with serious emotional disturbance. So we serve a whole bunch of folks under that. And at the time in the late 90s, early 2000s, CMS had told us to use this particular authority, and so when you guys start researching, and these are again the things that your governmental partners can do, start researching under what authorities you want to do things, because you have to have the federal authority in order to spend the money. So you've got to have some policy wonk that's going to say to you, okay, I understand what your vision is, but now we got to figure out how to fit that into what the feds will allow us to do. And Rick just so eloquently pointed out, and we all know when we're waiver managers, when we're dealing, CMS has requirements, and they have lots of requirements. And so you want to make sure that you've got your governmental folks at the table to help you figure out how to write that authority in a way, or write your request in a way that you're going to be able to draw down that federal money without running into questions about you can't do that. That's a long way of saying they told us to use this one authority. The problem with that authority was it was not an entitlement, and you heard that word used. Entitlement means you have fair hearing rights. These were additional services in lieu of, alternative services. In lieu of state plan services, there was no fair hearing right, and that was a big challenge for our system. You talk about how it evolves. When you don't have any fair hearing rights, it's easy to deny, and it's hard to get that overturned, right? Then they turned around a couple years later and told us, no, never mind, you need to use a different authority. So you guys can feel my pain on that. But in 2000, we had to re-procure. And you'll hear that word if you go to do a managed care system. You have to procure your providers. You have to actually go out and get bids for things. And they wanted us to go competitive. They wanted us to do competitive bidding. And we, just like Rick so well stated, did not feel that it was in our values in Michigan to turn that over to for-profit entities. And so we wrote a plan for procurement. I'm going to talk about it in a little more detail in a minute, in order to convince CMS that there was another way to do it, that we didn't need to use we didn't have to use the public. I'm saying it wrong. We wanted to use the public sector. We wanted to use the nonprofit. We did not want to turn this over to for-profit entities, because we just couldn't balance that concept of how do you take a profit out of what could be turned into more services, right, or improvements to the service. So I'm going to stop there and turn it over to Angela.
So in terms of how our involvement in the disability advocacy community involvement was, it was intimate in terms of really pushing for this managed care arrangement. In fact, the state, Deb and I were talking, and dating back to that time, I remember going to 3 of the 10 town hall meetings. Okay, there it is. So at the time, the state was inviting people to give feedback on the application, literally asking for our feedback on what we want included, and very down to the very details of service array, potential supports, the layout and structure, both administratively and geographically. You saw our map just a few minutes ago. Michigan is a vast state. There are regional differences. There are local preferences. If you don't live, I'm going to give you, is anyone here from Michigan? We're going to use Michigan lingo. Okay. Are you a Youper? Okay. Are you a Youper? Who's the other Michigan person? Are you a Youper? Who's the other Michigan person? Just one Michigan person. There is such a thing as being called a troll if you live south of the bridge, and it's not an endearing term. So having said that, there is this regionalism that you have to be very careful of. And the state was very cognizant, rightfully so, in past experiences, but the disability community is also very cognizant of that, and that we want local control. We are a purple state in Michigan, and we'll hopefully stay a purple state, but that also means that we stick to the idea that we want to have local control that represents local resources and local connections. The state asked for our participation and support, and there was some pushback from the system itself, to the point where a bunch of advocates literally went to Chicago to meet with our regional staff, CMS regional staff in Chicago, advocating on behalf of the state to say these are the reasons based on values, principles, service direction, and service array. This is why we want managed care in Michigan. You don't hear a lot of disability state people coming together on that value set, but when you're invited to work in a direction that we could see that the more that we kept the money in the hands of the person, as close to the person as possible, the value outcome would be for a person's enhanced life. So that's why the community was willing to go on a limb and really advocate on behalf of this partnership. The realities of keeping that local control, but the minimum requirement for application with what came up, and we're going to show you a map in a second, was this standalone system of a prepaid inpatient health plan that had to serve at least 20,000 minimally. And that can look different based on who got in the same team and played together and put an application forward. But the important things about having that local standalone control were that many CMHSPs that were existing, that's the community mental health service providers that were already in existence, Michigan has 82 counties, and that were already in existence, could come together and reformulate into a prepaid inpatient health plan. So we weren't, as Deb had alluded to, bringing in for-profit outside entities to then come over and take over Michigan's system. We were going to really had this nonprofit commitment to do so.
We're going to share one mic and keep that other one off, and we got a little bit of technical assistance, so now we're even more collaborating. Yeah. So I'm taking the first bullet, and Angela's taking the second bullet. So the outcome of this was we were able to articulate to CMS that we needed, CMS being the Centers for Medicare Services, Medicare and Medicaid Services, the feds. We had to articulate to them why we wanted to use our local community mental health services programs as our base for that service delivery system. Our arguments were that this was the set of entities that were most familiar with this population, and if you were to read this plan for procurement, it's a combination of economics and values. And you mentioned that you have to stick to your core values, and it was right in our plan for procurement. But a lot of our argument was economic. It was, there's a public good, there's a market failure with this group. This is not a group that the typical historically known managed care system is going to serve. Nor are they going to serve them in a way we want, because we value community-based services, and they are typically a medical service delivery. You have a problem, you come in, you see a doctor, you go for some tests, you have surgery, you go through the hospital, you might go through rehab, whatever, you go home. We have long-term supports and services. We have folks that we're not looking to have them get better. We're hoping to have them have better lives. That means lots of supports and services that don't look anything like what a typical managed care system would do. And one of our arguments was, if they were going to do it, they would have already been in this market. But the local community mental health services programs in our state were set in code, in our mental health code. They are our local entities. They are closest to the person. We try to have as much local control as possible. And so if you were ever to read this plan, and there is a link on one of the slides to be able to go out there, because it's on our website to read it. It's quite the read, and you have to be ready for the economic gibberish that's in there. But it was a very compelling argument. But what made it so successful was the face-to-face time with our advocates, who went on behalf of everybody in our state and sat down with CMS and said, and here's what it means to real people. Here's what it means and what it would look like in our state. So now I have to hand it back over to you to talk about those values.
So the values of freedom, participation, inclusion, integration, and my real ultimate value is citizenship. The services that we're talking about are supposed to, I mean, that's why somebody is, as you can think about it, somebody comes to the system with these ideals. If they don't have a disability, we would expect that the services they would use would then provide the outcomes. People with particularly complex needs or developmental and intellectual disabilities, that should be the same ideals. It should be the same outcomes of citizenship. You use supports and services to have a meaningful life. We want you to have freedom that is an expression of how you use the supports. Freedom to choose things that reflect your value, your personal value, but with the goal of being a participant, being a contributor, being part of your community, being in your community, and having a contribution to give back to the community. Not just simply seen as somebody who is a service user and not a recipient of supports who is then contributing back to the community. So we're going to share with you some of the service array later to demonstrate the expression of that. But it's very key, and I think particularly also when we're talking to outsiders in terms of advocacy, outsiders, I think when I'm saying that outside the knowledge of the disability community, that they see people that we support as citizens first, in terms of both at the advocacy level with our legislators, and we were just thrown aback when we saw 3 legislators in this room, which is just unbelievable, which we are, and that's incredible. But talking to our legislators to have them see that citizenship is our goal with service delivery, so that when we are making changes and improvement, that's what we're trying to achieve.
So just real quickly, Angela had mentioned she went to some public forums. Some of the way that we got the stakeholder input, and I'm sure you guys, with this forum are already moving down that path. We had 10 different public forums all over the state. We kind of have a running joke that we try really hard to not have to go to the UP in between the months of November and April, because you can get stuck up there for days. And sometimes they shut the bridge down because the wind is so bad. So I'm pretty sure we had those forums in the summer. We got over 750 comments, and anyone who has to do that side of the business knows you must respond to every single one of those comments. So it was clearly a very important issue for a lot of people. And I think you guys are going to find this list very relevant even today. Now, this is what was generated in 2000 and 2001. But we hear the exact same things today. And we're one of the states, as is Washington, working through the integrated care dual eligible project, and we're hearing exactly the same concerns again. You have to be mindful of these issues when you're going to build a system, because ultimately people want to know that the relationships they've already established are going to continue. They want to know that the providers that they trust to do some of the most intimate personal care things with them are going to be those same people. They want to know that the person's going to show up the next day who they were expecting to come. They don't want to lose all of that just because we want to change the way we fund the services. So you always have to be tuning back into what's our mission, what's our purpose, what's our values, and we really want to make sure that we can assess and assure that we can address these kinds of issues. You want to add anything to that, Angela?
Only to say that that will also, that assurance of people having that safety net for them makes them feel confident that they can continue to have lead a meaningful life. There's not this always panic state of what if they change my provider, what if they make me move to another community to get this service. That was always something that the state was very honest, forthcoming about, that this is how we're going to make sure managed care is going to help us maintain local control. So this is the wonky map of Michigan that came out of those forums, and there was 18 PIHPs, prepaid inpatient health plans, and Deb's going to talk more about what their role and responsibilities were later. But as you can see, there was a couple that could stand alone, that meeting that minimum Medicaid covered lives threshold, and they could apply directly. I live in a county that is the second largest county in the state. My office is in Wayne County, which is part of Detroit and is the largest. And within those just differences between those two neighboring counties, the implementation was even just slightly different. Again, having that local flair. But then you can see like some places skipped and jumped across the state to get that minimum number of lives, and had to meld that culture, that administrative, financial, quality arrangements that really pushed some of those states to do some hard understanding of themselves. And I think overall, as time continued to pass, some got better and better as they had to work through some of these issues.
And let me just add a quick little side story, because I think the legislators in the room will appreciate this. You see that beige, very spread out group? You've got this kind of centralized, and then you've got this one, and then you've got that one way up there. So here's what happened. We wrote that we wanted states to be contiguous, because we thought if you're going to create a region and you're going to put services within a region, that they should all be like kind of touching. And one of those, and you can figure out it's a 50-50 flip, but one of them said, we don't want to be affiliated with that purple group. We want to be affiliated with the beige group. And so the legislators came through and redefined what contiguous meant. And contiguous meant within 30 miles as the crow flies to the closest place between the two. And so you have the Newaygo, which was 30 miles tip to tip from Ionia, and then you had Manistee-Benzie 30 miles tip to tip from the other. But I can tell you that over a course of years, what we've discovered is, as Angela was saying, it hasn't worked so well, because there's extremely different cultures. The middle of that beige area is the state capital, where I live and work, and there's it's an urban area, and then you get Manistee-Benzie that's up there on beautiful Lake Michigan with a very different culture, very different needs, and so far removed from what we would call like a hub that it just wasn't working. And at the end, we'll show you, but we're actually in the process right now of reprocuring, and we're going down to 10. And we defined the boundaries this time. So,
is that they also learned from there's a learning curve for the system as well, that they learned how to pick their playmates better when it came around this time around, some almost 10 years later. The other thing they also figured out is that it showed some real true colors of where the individual organizations were to the state philosophically and the local communities philosophically. So some had to pull their brethren up a little bit farther up the values chain, and some fought with the administrative seat to say, hey, no, we're going to push the system farther. So there are positive and negative outcomes, but it's that learning curve that happens when you redesign a system to push it to the next level.
So just very quickly, so obviously we have a managed care system in Michigan. We call it our Specialty Supports and Services Plan. That is, again, our 1915B, which is the big managed care, and then we have this concurrent 1915C, which is a habilitation supports waiver. That was the waiver that we started with in the early or to mid 1980s that was designed to either prevent or remove people or bring them back to the community from institutions. So that was our jumping off point. We took the services that we had listed in the HAB waiver, as we call it fondly, because habilitation supports waiver, another one of those mouthfuls, and use those as a basis for designing our service array for people with intellectual and developmental disabilities. And then as we evolved, we realized, well, wait a minute, some of these same services people with mental illness also need. And so why do we have this bifurcated list of services, one for people with MI and one for people with DD? And so we combined and consolidated those in one of our 2-year renewal cycles. So the list of services that you're going to see here in a little bit is available to any of our Medicaid beneficiaries. So we're contracting, the state is contracting with these 18 PIHPs, these prepaid inpatient health plans, and that's a title that comes from the Balanced Budget Act that has all sorts of rules and requirements around managed care, all right? So these are PIHPs, and the reason they're a PIHP is that inpatient word means that ours have the authority to, they have to pay for, but they have to authorize inpatient services, which now is only for people who have mental illness because we don't have any institutions for DD or for folks with intellectual and developmental disabilities anymore. We pay a capitation payment on a per eligible per month, and that is different from what I heard Rick describing because they're paying on a per enrollee per month, I believe. But everybody who has an intellectual and developmental disability is enrolled in that plan. For us, the way we do it is per eligible per month means any Medicaid beneficiary in that region is potentially eligible for services. And so when we said 20,000 covered lives, what we meant was at least 20,000 Medicaid recipients in your area, and then we pay on a capitated basis a small amount of money, but only a percentage of those who are eligible are actually going to come and request services, right? Because if you have 20,000 eligible Medicaid beneficiaries in a region, maybe only 2,000 have an intellectual or developmental disability. But by paying on a per eligible per month, it really does reflect a bit more what a typical managed care system would look like. It's based on all of those risks and actuarial calculations on if you have a set of members, not everybody's coming in and needing the most expensive of everything. And the way they make their money is because if they have some healthy people who don't need a lot of services, and then they have some people who need a lot more services, at the end of the day, if they have more of the healthy, don't use a lot of services, they're going to make a profit, right? So what we do is pay on a per eligible per month, which then takes out the incentive to cherry pick. You guys know that term, right? You pick off only those that are going to be the lowest cost so you maximize your profits. So we also have a not-for-profit system, and we have a shared risk arrangement. So we have risk corridors. The first 5% that they would spend over what we have calculated is all on them. The next 5% is a split between the state and the PIHP, and if some entity were to exceed by 10% what they were supposed to spend, it would all be on the state. Now, we watch that very closely. We've never had that happen. If somebody did look like they were going to be at risk of moving through that risk corridor, we would need to implement probably some more strategies, like up to the point of taking over that PIHP and or ending their contract and moving to another entity. But they can save some money as well, and they can put it into kind of it's an ISF, and off the top of my head, I can't remember what it all stands for. Somebody else in this room probably knows, but I know the F is for fund. But it's kind of like their rainy day fund, They can save a certain amount of money, but they can't keep it all. And then they have a bit of money that they can turn over the next year and use on Medicaid services. So if they don't spend everything in one year, they can keep some of it, but they have to spend it on Medicaid services. So they can't go build big buildings and that kind of stuff. We really have tried to build into the system, we limit how much administrative costs can be. Those are the kinds of things you do in a managed care system to try to move as much of the money into services as possible. We're always working on that. That is, as Rick pointed out, it's a never-ending thing. You have to keep going back to the table to try to remind everybody what our values are and that we have a certain amount of money and we have to spend it as wisely as possible. Anything you want to say on that one? Okay, moving on. You going to do this one? No, I'm doing this one. Okay. We figured this out last night while I was having a bowl of soup at about 9 o'clock or 8 o'clock. I guess that's 11 o'clock our time? Yeah. Okay. All right. So we have an extensive array of services. We're going to show you that list in just a minute. And if anybody ever wants to go out and look at Michigan's service array, we have a link on this to the Medicaid Provider Manual. So you could just Google Michigan Medicaid Provider Manual and go in there and look for the mental health and substance abuse services chapter, and it will take you right to any of these services. But we have a very extensive and flexible set of benefits that really emphasize the individual's choice and control. Our practices are all based on these principles. Person-centered planning. We were the first state in the country to have person-centered planning as law. And the federal description of person-centered planning came pretty much from Michigan's language. So we have been a leader in that for a very long time. And then we also value family-centered care when you're looking at children, and youth-driven system as well when you get into adolescence, so that as the child grows toward adulthood, we shift from family-centered practices to youth-driven practices to person-centered practices as people reach adulthood. And then we have this little limited outpatient mental health benefit that's available through our medical side of the world, the Medicaid health plans, because we have a managed care system for our Medicaid health side of the world, and we have a Medicaid health plan that's our managed care system for behavioral health. So there is a very small benefit for folks that they don't rise to the level of needing our intensive behavioral health services. So our key features. You want to cover this one? This is such a cool slide. You should do this one.
I think this is the one when I say this to outsiders. Deb and I were just both sharing this last night. When you say the word no waiting list to outsiders, they're like, oh, come on, you've got to be joking. You have to have a waiting list somehow. We don't. Because, again, based on the structure of how they financially set it up and the arrangements of what's required of the system is that there is no waiting list. So you present yourself as an eligible beneficiary with an expressed need of support, and the system has to serve you. Really key. The next thing I think is incredibly important is if we really believe in citizenship, and you believe that Michigan citizens can live anywhere in our beautiful state, that portability of being able to receive services anywhere, not in some relegated place based on a particular set of service array that person might use, that then relegates them only to a certain, region of the state, wouldn't be a full realization of that. So that portability is really key. The array of services, and we're going to share with you some of that, but the primary service delivery is in the person's individual home and or community. And that's their chosen home and community in the community, not in some artificial notion of community. We're really talking about community-based supports and person-directed supports. And that comes from that expression of the law. Having person-centered planning is the essential planning style for how your supports or services are arranged. Moving completely away from that medical model and moving to person-centered planning. And it's really honoring the process that the person drives the decision-making, the discussion, the details of what's talked about and not talked about, which I think is a really important thing, really move towards person-centered planning. And then when you look at that in terms of system redesign, self-determination is a requirement of that contract offering, not just to people in a certain particular group of, and we were talking about this with our colleagues from Wisconsin, not just the folks in this group over here, but that everyone can get it. And my work in a person and working with people that are service recipients is helping them to figure out how to set up those arrangements in their own lives. And if it's just starting with one support where they're really having direct management over, to maybe a couple more supports, and then how to use the system and arrange those service arrays so that they're having greater control and greater decision-making over their service arrangements in terms of delivery, in terms of who is providing services, when it's provided, how it's provided. So the self-determination is a key feature across the system itself, not just to a select group of people in a region of people.
So just very quickly, we wanted to give you a visual of who we serve. So you can see in this pie that the white slice are our folks that we serve with intellectual and developmental disabilities, and that's all ages, and that's including people who have a dual diagnosis of mental illness and developmental disability. So you can see that it's about 43,000, almost 44,000 people out of the 242,000 people that we serve in the state in our managed care system. But when you look at this slide, now you see how much we spend on our supports and services for those individuals. And it makes sense, doesn't it? Because a lot of the expenses are going to be in those long-term supports and services, very little in the clinic services, the old medical model style. So you can see that we've now, although we're only like maybe a quarter of that pie, we've turned into over half of the expenditures. And what do we spend our money on? So if you look at the orange slice, that's our supports for living. So that's a service we call community living supports primarily, where we're bringing an aide into the home to assist the individual and or out in the community. The little slice next to it, which is that kind of purplish slide, says supports for family and caregivers. That's our family supports and training. And then respite. And then the kind of purplish one up there is daytime supports and services. And to answer your question, because you should ask the exact same question of Michigan, we are not great at supported employment. We can use the excuse of the recession as loudly as any state, but it is definitely one of our areas that we're working very hard to try to pull ourselves up, because we're not good at it. So a lot of that purple is day program still, unfortunately. Now, the one thing Michigan does have going for it is we have the longest time in school of any state in the country. We don't graduate folks out of our special education system until age 26. 26.
Doesn't mean we have better education.
Doesn't, that's right.
But very important thing. Well, yeah, if you can do it that way, that's where they would go. But that's also to say that some people shouldn't be in school till they're 26. I mean, let's be candid. That reminds that eligibility. It's the only state in the union that allows special education services up to the age of 26. But I again caution you. Our outcomes from our employment and our outcomes for education achievement are not better than any of the other states.
No. And in some ways, we're missing a window because they stay in school so long. Exactly. So it's a double-edged sword. It gives, families, it certainly gives some relief. It gives structure. People know what to expect up to age 26. And then, as Rick had said, they kind of fall off a cliff. We have exactly the same issue in Michigan. Exactly. And I have with our new reorganization, I now have the specialist who oversees our supported employment working for me. And we're very much interested in trying to advance that agenda. And to the point that Rick had made, I just love being able to look at his stuff and go, yep, exactly. Where you have to value by putting your money where it is you want those things to happen. We have to figure out ways to slow down the funding of those day programs in order to have more available because we have a finite set of money. We're not going to get new money, as everybody knows. We have to figure out how to use it differently. But so we're struggling with the supported employment piece of it. But we have had some success in the supports for living piece. I'm going to hand the mic back over to Angela to talk about how the system shifted.
Respectfully, I could say that our state can help you on that with the supported employment. We're a mentor state to Iowa, Tennessee, and Oregon from the Department of Labor.
And I appreciate that. I think our specialist is starting to connect with there's like a whole network, right? The SELN network. So I just signed the contract for him to be able to be on that SELN. So I appreciate that. I'll make sure that, I get your information and Joe can connect with you. That'd be great.
I will say, and the supports for living is we know we're going in the right direction in terms of where community supports are being delivered, or that supports are being delivered in the community versus in residential or segregated settings. I know for my own sibling, the majority of her individualized budget of services and supports, it's almost all community supports. It's to develop and she is a small business owner. She is going to community college, to answer your question, and she's one microcosm. She's just one person. But that's where people are using those supports to have a pursuit of business, continued or completion of their education, to be a contributor in the community, a volunteer, civic organizations, but using those supports in a way that is person-directed in the community, and to again, keep bringing it back to that word, because it's really important, is the full realization of citizenship, is that those are how the supports should be used. I would personally like to see it all be that, be in fact that, because if we really believe that people should be in the community, well, wouldn't you spend every dollar back in the community? It wouldn't be, we get even farther and farther away. I mean, some people are going to have some medical needs. That's not to say that we're not going to have some of those. These are folks with complex support needs. But when we start to fill up that other pink section with more community supports, then we know that they're really stamping down and pushing those things into the community, supported employment, supported living. It's all going to be a much bigger pie. So maybe we'll come back in 10 years and compare notes with Washington State, and our pie might look a little different.
I'll fly in from Hawaii for that one. 10 years, gosh. I would not want to stand up here and say, I've been working for the state of Michigan for 40 years. Whew, that sounds like a long time. Oh, this is your slide. You should definitely talk about this.
So the things that we were, these are just some expression of examples of things that we got to help the state with. Certainly policy development, writing the policy about person-centered planning, and then advocating for its implementation in the Medicaid manual. I mean, that to have those words in there is one thing, but then to have it into statute is a whole other thing. And that was the collaboration that really realized that person-centeredness. Policy revisions, Deb has been, we have a group of advocates that meet regularly, and she's always been coming to the group to welcomely have a conversation, a dialogue about the definitions of medical necessity, of service array, of drafting, editing, even for the applications of the waiver. She's always invited that collaboration, and not just Deb, but also other, the leaders of the department. Things like person-centered planning, even getting farther down the path of having independent facilitation, somebody independent of the system, a true third-party person, facilitate the planning process. Oh, and by the way, get paid for that service. That's really putting yourself where you really stand in terms of principle. I mean, putting your money behind it, again, is where you demonstrate that it's a full expression of that. And then I think the other thing is, again, the self-determination is for everyone. It's not for a select group. In the whole practice and system redesign of self-determination, some states, getting to talk to other states, they have, quote unquote, creamed the top on this. People with very not complex needs, maybe a low level of support needs, have been the ones that have been able to self-direct because it's not been difficult for systems to do that. We've said in Michigan that that's for everybody. And the reason we want to say that is we do have the folks that have high support needs, complex needs. They should have their experience in directing those supports are equally important, and as somebody who might have just a few needs. And I think in terms of looking at the bifurcated system of folks with developmental IDD and mental illness, that's one thing that Michigan continues to recognize as a self-assessment, that we have to get better in helping folks that experience a mental illness to get better about having arrangements, support, self-determination. They have to have greater control. We've done really good in supporting people with IDD diagnoses, but we've got to get better job at doing that for folks that experience mental illness.
Okay, so now we're back to that crazy authority thing. I don't want to talk about the authority. I want to talk about how we defined medical necessity, because this was, in my humble opinion, a groundbreaker. And it required us to have a lot of support from, and of course input first, but support from our stakeholders, folks that are using the services and living lives, to say, here's what I value, here's what I want to see in there. When you talk about medical necessity and Medicaid in the same sentence, inevitably people think doctor's office, lab, that kind of stuff. When we talk about medical necessity, because you have to meet medical necessity in order to be able to obtain a Medicaid service, okay? So our definition of medical necessity are those things that are highlighted. Community inclusion and participation, full community inclusion and participation, productivity, and independence. Those are our medical necessity. And so if someone with an intellectual or developmental disability has a goal to be able to develop a micro enterprise, that's a productivity need. If they they want to be able to do more for themselves and they need someone to help teach them how to take care of those personal care activities, that's independence. If they are out in the community trying to develop relationships or whatever it is that they want to do in the community so that they're around every other citizen in the community, that's community inclusion and participation. So the goals that people have in their plans of service tie back to one of those three: medical necessity. And look at how closely that ties to our values and principles. So going back to what Rick said about how you have to literally operationalize those values in ways that are tangible, we believe we've achieved it. We've had this in there for how many years now? 6? I think 6 years, maybe 8. And other states call us all the time and say, how did you do that? We discussed it with our partners at CMS and explained to them why we needed it to be written this way in order to achieve what we were trying to accomplish, which is truly a community-based system of care that's managed and enables people to have the lives that they want.
So the other thing that's really important, this is right from, the state has put out, this is one thing that we really get to do. Myself and other colleagues and service recipients and advocates get to give this work with the state directly in developing the policy and practice guidelines. They fully embrace the collaboration and the community, external community at the table. And there's a self-determination. This is also, when I talk to other states, something that they find very unique is that we have a policy and practice guideline. We have a self-determination policy. And I think this is right from the policy statement. This was just updated last year and a good self-reflective system will update things regularly, which is really important. But it says the components of meaningful life include work or volunteer activities that are chosen by and meaningful to the person, reciprocal relationships with other people in the community, daily activities that are chosen by the individual and support the individual to connect with others and contribute to his or her community. I mean, that would be a statement that would reflect any one of our lives. That's what we would hope that we would use and have in our daily life. The other thing is also in the explanation and implementation, there is an age appropriateness detail, so that we're not expecting young people at 14 to go out and work 40-hour weeks, and we're not expecting somebody at 70 to not see that retirement is part of their future. That we don't expect people to do things that are not in rational thinking to what somebody else, their non-disabled peer groups would be doing.
I want to add one quick thing. You'll see there's an extra bullet point there for recovery, which I didn't have on the previous slide. This is really targeted for our folks who have mental illness, serious mental illness, because we have a recovery-oriented model of care as well. So if you have someone who has an intellectual disability and a co-occurring mental illness, they may also be using that piece as part of their medical necessity. So I just wanted to point that out. So here's our list of our services and supports. We have assistive technology, which includes those things that are not going to be covered by your typical Medicaid program. They're not going to be covered by your third-party insurances. They're going to be those things that are, like an example might be an iPad for someone for communication, a kid with autism who needs that iPad in order to be able to make their needs known, and that's not going to be covered by traditional Medicaid. So they are those things that enhance the traditional coverages that we have. We have community living supports, which we've already talked about. That's our aides that are going out and spending time with people in their homes, in the communities to assist them. We have enhanced pharmacy. It's a very small benefit, but what it is it's for what we call those medicine cabinet kinds of services where somebody living on their own, if they need Band-Aids and first aid equipment, or the little stuff you would buy at the drugstore, vitamins, minerals. There's also a thickener aid agent written in there so that people who have trouble swallowing and need the thickener, because it's expensive, and it wasn't covered by regular Medicaid, so we put it in as an enhanced pharmacy. Environmental mods, ramps, bathroom modifications, those can be fairly expensive, but they're usually only one time, and the cost for that one time to support someone in their home can save lots and lots down the road. Family support and training, we've already talked about a little bit. Fiscal intermediary is our entity that would manage, along with the person, their individual budgets. Housing assistance is a very small, short-term kind of assistance for somebody while they're waiting for maybe a Section 8 voucher or whatever they're called now. I'm sure that's not the right term. Peer delivered and operated. We have peer mentors in our state. We have certified peer specialists for individuals. There are folks who are recovering and they have had experiences with serious mental illness, but we also have peer mentors who are people who have intellectual and developmental disabilities. That's a relatively new addition. Prevention direct service models are some of those evidence-based things. Respite care, very important to support families who are caring for an individual in their homes. Skill building, and there's also supported employment. Skill building is kind of where the day program right now is sort of kind of falling, and we need to be moving away from that and more toward our supported and integrated employment. And the terms that Don uses, customized and something else. Customized employment, I know, is we're going to need to tweak this definition. We have wraparound for kids, and then we have a couple of that residential treatment and subacute detox are for people with substance use disorder. We don't have residential treatment as a service for our individuals who have intellectual and developmental disabilities. So as you can see, that's a pretty broad swipe at services.
In your handout, I'm sorry, there's handout number 3, I think, is an excerpt from the brochure that the state has published regarding the alternative 3. I think it's on maybe page 9 and 10. I wrote it down, and my screen just went silent on me. But it gives you the listing as well. Community living supports, again, the explanation of it, people use it to participate in the community, to have access to the community in terms of, using it to maybe have a small fee paid for an admission fee, and then maybe also an enrollment fee in a class or something, we're paying for the direct. So it's a bundled service that can pay for more than one thing in a collective rate. This is where you can use it to either purchase a self-directed arrangement where the person is also directly hiring and identifying the employee that will provide that, or you can buy a provider arrangement for a contracted service, or you can do a combination of both. And that's the other key feature. We did provide, the very first handout of the back provides a comparison of the arrangements that are provided under the service system, both the agency with choice model and the self-directed model. Family supports and training, Deb touched on this, but I think the one thing here is that it provides the opportunity. I know our organization had a funding from the Administration on Intellectual and Developmental Disabilities for a long time, and under they're called the Projects of National Significance, PNS grants. We had a family support grant. We developed a pilot project to then do family support navigators. We have now spun that out to our local CMH entities where they've trained staff now who are qualified to provide family support navigation. Their whole goal is to help families navigate the system of supports, either enrollment at transition, enrollment of their son or daughter who is an adult and maybe hasn't access. But that's a person that's on staff working as either a contractor or on staff at the local CMH to help the family and that individual navigate into the system. And that's family support and training. Peer-delivered services, huge. And I have to say, the advocacy community of folks with intellectual and developmental disabilities really called the department to task until about a couple years ago. For a long, long time, there was the healthcare code of peer support specialists, and they kept saying, oh, that's a great code. What about us? Oh, okay, yeah. Peer support specialists, peer support specialists. And there was a lot of people getting hired. The state really invested quality-wise. They have a full-fledged training program. And we had a director who came in and said, we are going to fully realize the equality of our system, and created a code for people that supports people with intellectual and developmental disabilities. The key writing of those definitions is important, that they have to have used the service system themselves. and experience the diagnosis as well. Because that not putting that they have to be a service user was particularly important for the peer mentor role, because there are, let's be frank, there are people that have a disability, a developmental disability, that may have never used the service system. They can talk to the experience of having a disability, but they can't talk to the experience of having to access and walk through that complex system. So that was a really key important feature. Yes, the DD Council was a key collaboration. In fact, both DCH, Department of Community Health, and the DD Council, our state DD Council, shared cost and shared planning for that preparation and training, and have statewide continued to make that investment. Fiscal intermediary services. In Michigan, these are some of the services people might have. The bare minimum in terms of the contract for the fiscal intermediary service. The state did a couple things that were really important. First of all, they created a standardized qualification packet, which measured all FIs against. So in order to be considered an FI and provide that service, you had to meet the state qualification, which again provided that you could locally choose who it was, but we're not going to give up on quality. So the state did that, and then provided and trained, prepared potential organizations. Each CMH or PHP must have at least one FI on contract. Now, some have more than that, and some have different arrangements. The power here, and Deb and I have talked about this, is where you can really do some quality that reflects more of the greater needs and the wants of your local service recipients, is that you can negotiate new arrangements, meaning you can go from a FI service that's per check, a percentage of the total budget per person, or a monthly service charge, and then listening to your community to say which one better fits our community, and then also listening to your community to maybe opening up to more FIs to create greater competition, which then increases quality. I know for Detroit-Wayne County, there are 7, and that doesn't just reflect regional local communities. It also reflects that people didn't like this one. They said, okay, I want to go have this local accountant do this job, and have them be it. So it's an opportunity to improve quality. Person-centered planning, we have touched on this again. This is right in our mental health code, so you can pull this act up. I know other states have asked, where is that? Let me get that language. And you can actually pull up the definition, and then also pull up the definition of what an independent facilitator is as well. This is exactly what our role, our managed care document says. The self-determination policy and practice guide, which is updated in 2012, says about our system. Self-determination is a value that people served by this public mental health system must be supported to have a meaningful life in the community. And then recognizes the principles, again, that reflect access and directed needed supports that a system in pursuit of their life with citizenship, responsible citizenship. And obviously each of these words kind of jump off on that direction. So the principles here, and this is written in the policy and practice guideline. This is taken right from. We helped to develop, in collaboration with the state, to develop these actual definitions of freedom, authority, support, and responsibility. As a disability community, we've really pushed the state to include the 5th principle that we in the disability community want, but it didn't get in, but it's there in philosophy. But the self-advocacy community wanted us to include the word confirmation and the role of self-advocates redesigning and pushing the system forward. But the ability to control some target amount of dollars that meets your individual needs so that you can organize in a way that you have decision-making over who provides the support, who's contracted, and then to be responsible for using these public tax dollars in a way that is both legal and responsible and not using more than what you need. I think it's a really important thing, and I'm going to put my family hat on right now, and I know in the quiet tenors of some family conversations, we can sometimes say, well, I'm going to make sure, there's those outliers that can say, I'm going to make sure that my family member gets everything that they need, everything they're eligible for, not everything that they need, everything that they're eligible for. You can't create a system for outliers, both for underutilizers and overutilizers. You have to create that system for the majority in the middle, which is most people anyways. It's the bell curve. You know, researchers and statisticians would tell you, you create for the 66%, and then you worry about the ends. That's really what we're talking about. And self-determination says that we respect for the idea that people are going to make sure that they take only what they need to make sure that the next person can get served in that same person-directed way.
I just want to add one quick thing. because we're in the discussions about the dual eligible project, we heard loud and clear from all our stakeholders that this was a value that they wanted to see in that system as well. We got what, how much time? 5 minutes, okay. Oh, 15, oh, good. Thank you, because, great, okay. Thank you. Thank you for being a timekeeper. And these same concepts are coming up in that discussion, and they're looking to the behavioral health because we have such a well-defined and developed policy, looking to us to incorporate that and require training by somebody from the state on self-determination and person-centered planning for all of our managed care entities, which of course will be the for-profit companies, because this is really a medical side of things. So we're just going to move past this really quickly, if that's okay, because all that's doing is giving it another way for those same medical necessity things. Now, Rick already did a nice job of talking about safeguards and protections. We just gave some language out here that shows that we also are very mindful of that. One of the things that I do that I find extremely helpful is I have regular meetings with our administrative tribunal, which are the judges that would hear cases. We don't talk about any cases, obviously, but we talk about the policy, and we talk about the kinds of things they're hearing, the kinds of things that they see when individuals come in front of them and are asking for, either some relief or increase or whatever of services. And then that helps shape policy. I also, every time I can get an opportunity to go out and talk to people who are actually living lives, it helps shape our policy, because the more we can put in writing, I think sometimes it really helps the foundation so that everybody's very clear on what the intent is, and you don't have as many hearings. It's very stressful to send people into a hearing situation. We try to avoid that if we can. So a lot of that comes from very well written, very clear policy, and lots of education and empowering folks to understand and be able to ask for it. One of our favorite things to do is to say to people, take that page from the Medicaid provider manual with you and say, show me where it says that I can't, or that you said I can only have this much when I say I need more. So we do try to do a lot of outreach in addition to the traditional grievance and appeal process. This is just a brief list of some of the things you have to keep in mind in a managed care system. You will have the Balanced Budget Act requirements. You have to make sure that you address all of those. It requires a quality improvement strategy. We're in the process of rewriting ours right now because CMS just issued a new toolkit template, which is turning our quality improvement strategy on its head, which it was probably time to do anyways. It requires an external review by some entity that's going to be independent. You get into that conflict of interest piece. You want a neutral party looking at your system. We have a DD practice improvement team, which helps guide our policy and best practices. And then we also have those 1915C waiver requirements. There's lots and lots of extra requirements around a C waiver that actually help drive the development of our critical incident reporting system. It was kind of all over the map, and then we were doing a renewal, and the feds came back and said, this isn't acceptable. So we thought, well, we have to put the system together. Why put the system together just for the 8,000 people that are on my HAB waiver? If it's good for those 8,000, it's good for the 242,000 people that we serve. So we created a system for everybody. But the driving force was the requirements from the C waiver. So we're back to an evolution slide very quickly. So in 2009, as I said during that question, we closed our last ICF, IID as it's now called, Intermediate Care Facility for Individuals with Intellectual Disability. That's a mouthful too. We closed our last one in 2009. In 2013, we finally were able to, we got a 1915I, which is a new authority under the Social Security Act for an autism benefit for our little ones. So we're now serving kids 18 months through age 5 to get that early intervention service package in there, hoping that down the road that's going to save a whole lot and, most importantly, help people live lives that might not be as affected by autism as it would have been. And then I have this, 2014 will be a big year. And I say that because if we survive it, or me personally survives it, it's going to be amazing because we are literally turning the system on its head totally. We did an application for participation. We're now going to 10 regions, so we're realigning the entire system on those entities. We are in the dual eligible pilot, which has a behavioral health and DD component, and we are trying to get CMS to allow us to leave our existing structure in a two-tiered system, if you will, where they are wanting to go with this integrated care organization, but we have this managed care system for PIHPs, and it's a struggle because they don't understand, and we're trying to do something that just doesn't fit the model that they defined. We're getting there. We've made a decision recently that we're going to ask for another 1915I state plan amendment, and we are going to sunset our 1915C waiver, the one that we developed in order to help divert or move people out of the institutions. It's now irrelevant. That C waiver authority doesn't make sense in our world anymore because we don't have an institution to compare against. So we are going to sunset our C waiver and fold all of our DD services into a state plan amendment. And what that means for us in Michigan is that those services that right now are subject to this B3 authority will become state plan services. They are community-based services that are going to become part of our state plan. And then we also we're one of the states that has finally signed up to do Medicaid expansion. And that happens at exactly the same time that the 1915I state plan amendment would occur, and we would have to renew our B waiver. So we're going to be very busy. So if you do try to contact me, be patient. Might take a while. So here's our new map. We now have 10 regions. It aligns with the Medicaid health plans as well, and for the dual eligible pilots, you can see this very big purple center section that's huge. In terms of geographic, coverage, that's a really big area, and we'll see how that goes. So do we have a couple minutes for the videos?
Well, we'd like to take about 5 minutes, so okay. Should we show the video?
Yeah, great. Just to give you some background, and I'm going to work on David's kindness to help me start these. These are videos that we have created, or my organization has created. We find that it's difficult to explain it to people if you can't see it. That goes for people that are in the system and people that are receiving supports. So the first one we're going to show you is, these are videos we call possibilities to explain and show people what the possibilities are. The first person you're going to see is Liz, and Liz is a woman who has been self-directing her supports and hiring her own staff for a long, long time. In fact, and also has supported employment, and to give you the experience of what this looks like in a person's life. It's about a 5-minute video. So that wasn't Liz. I wasn't trying to trick you. That was Bjorn, Tom, and Dan. And that they have individualized budgets. They have shared costs, and that they live together and choose to share a space together. They have individual lives that sometimes intersect and sometimes lead very independent paths. The idea is that they are setting up their supports to use in a way that makes makes their life meaningful, not a collective group experience meaningful. I don't think we have time for the other Liz video, but I'm going to direct you on the last page of where our information is our website. So you can go, there's actually 6 videos, and you can see all of them, okay? Thank you very much.
Great, thank you.